But it is a real question, right? Is what in the world do? You can't ask Homer or even your kids. So do you want an interventionalist, right? And you got to think about this, particularly in the surgery clinic, right? Because what are we? We are looking for that nail, right? We're swinging the big hammer. And the problem is I tell some of the patients that keep coming back, I'm like, I'm a whack-a-mole specialist. If you keep coming in, I'm just going to keep whacking on things. And that's a problem. And we have to sort of restrain ourselves at times, and perhaps that's the point of the PERT team. Because there is a dark side to intervention, right? And that is this, and that's intracranial hemorrhage, which is frequently a lethal event if that happens after thrombolysis. So I'm going to go through some of the interventional options, devices, techniques, talk about some recent trials, try and skim some of the stuff, go over the guidelines, and then talk about the activity here at Houston Methodist. So obviously anticoagulation, systemic thrombolysis, catheter-directed interventions, I'll leave that sort of broad, surgical embolectomy that Dr. McGilvery will talk to us about, and filters. And again, the reason to think about something more than anticoagulation, as we talked about, is because of the risk stratification. The higher you go up and the more problems you have, the higher your mortality, and perhaps interventions other than anticoagulation alone can affect that. So our options, again, are the things we've talked about with lysis, either systemic or catheter-directed, catheter fragmentation techniques, catheter aspiration, surgical embolectomy, or the filters. You say, well, what about the filters, right? Designed, proven to catch clots, etc. But you put up filters nowadays, and it's just boo, right? From everybody with the lawyers. Dr. Wazowski was kind enough to even say that she occasionally does recommend somebody gets a filter, and we still think that does have a role. What are the indications? Well, it's for patients with VTE with contraindication to or inability to tolerate or failure of anticoagulation, and the other indications are really relative, right? PREPIC 2 that was mentioned earlier really failed to show improvement in patients that can be anticoagulated, that adding a filter to those patients has really not been shown to be helpful. But I think it's interesting that in the CHEST guidelines, they go through and say that in patients with severe PE or massive PE, and I think this implies patients that have to go on to pulmonary embolectomy, that some experts do have a filter placed, and that therefore they cannot recommend against that, whatever that means. So thrombolytics, contraindications, again from CHEST, the major ones, of course, are patients with known stroke, particularly that's recent, intracranial disease, active bleeding or recent major surgery, patients that are hypertensive, I think, is another thing that you really have to watch out for, and maybe even just a previous history of stroke. Systemic TPA we've gotten to be involved with several times. It can have a really dramatic impact. Our usual protocol here is 100 milligrams over 2 hours with 10 milligrams of that given at the first few minutes. Holding heparin during that infusion, then starting that again after the PTT comes back normal after the infusion stops. And that varies depending on who you read. Catheter-directed thrombolysis that you've heard some about really means using multi-side hole catheters, lower dose of TPA directly into the pulmonary arteries and clot, although clearly it does go into the systemic circulation. And then ultrasound-accelerated catheters with published data that we'll go over. So ultrasound-accelerated catheters, or the ecosystems, now have FDA approval for PE treatments and involves a multi-side hole catheter with the ultrasound units on the indwelling catheter inside that release ultrasound and again are thought to break up, fragment, and help penetrate the drug delivery into clot and hopefully accelerate that. It's usually done with 2 catheters done down into both pulmonary arteries unless there's just really heavy burden on one side and not the other. Catheter fragmentation essentially means taking pigtail type catheters, inserting those in and trying to break up the clot. Here's a progression in a series of images where a patient has really a mainstem pulmonary embolism with catheter going up and fragmenting and catheter aspiration along with that. Obviously not a perfect result, but is now able to establish some flow into the right lung the patient was not doing well with before. Catheter aspiration, right? So there's the angiojet catheter, which now has a black label warning on the box to not do this because of potentially fatal arrhythmias. The Inari or FlowTriever device that we've had some limited experience with here, where we go in and try and retrieve using a series of discs that you'll be able to see tomorrow in the hands-on section. Penumbra device that can also use this bulbous portion to retract clot down into the catheter and aspirate. The Vortex or the Angiovac that you've heard about that I think Dr. Lemson will talk about some as well. Severity of PE index, this is actually something you can get online or on your phone now. And again, if you have any one of these parameters, if they're over 80, cancer, cardiopulmonary disease, etc., hemodynamic changes, then so it's either 0 parameters or any one parameter is what the new simplified score is. It changes you from a mortality at 30 days estimated at 1% to 9% based on what you have. So recent publications to try and help. Pytho, we've talked about some, right? This is a randomized trial of systemic TPA. It's tenecteplase given actually as a bolus, and then that's compared with anticoagulation alone. And when it's looked at that in a big patient cohort at 30 days, so death or hemodynamic decompensation significantly improved with tenecteplase. Really, it wasn't death, though. It was much more the hemodynamic decompensation, but at the cost of stroke, right? So increased incident of stroke, most of which were hemorrhagic. So that makes that kind of tougher to look at. Ultima, relatively recently published trial looking at ultrasound accelerated catheter directed therapy with thrombolysis for PE. Only 59 patients in this group, with 59 patients in the intermediate risk PEs, persistent significance throughout the study time of RV systolic function, no intracranial hemorrhage. When it's looked at the early on, RV to LV ratios are thought to be the same. At 24 hours, significant improvement in the catheter-directed therapy group compared to the compared to the heparin group. Over 90 days that improved, but again, persistent improvement in the systolic function, depending on how you read that. Seattle 2 trial, looking at doing this for approval of the device. Single-arm trial, again using the ECOS device with catheter-directed lysis, not randomized. 150 patients, no intracranial hemorrhage, mortality of 27%, with improvement 48 hours of the RV-LV ratio and decrease in pulmonary pressures. Again, no intracranial hemorrhage, which is fairly important. So trying to step away from individual trials and look at meta-analyses for the data. In this one, it was published a couple of years ago, 16 randomized trials, over 2,000 patients, mixed massive and submassive, which makes it a little bit hard to know what that means, but again, systemic TPA given, all-cause mortality reduction by half, but increased intracranial hemorrhage rate. Right, so again, the odds ratio is high. The absolute number is fairly small at only 1.4%. Intermediate risk PE odds ratio mortality did improve as well, but again, a major bleeding rate elevated, but they did not specify for the intermediate how much of that was intracranial hemorrhage versus other hemorrhage. Here's another interesting paper that's come out just this year from Vanderbilt. It's a combination registry and a meta-analysis looking for catheter-directed therapy for pulmonary thrombolysis. So at a few institutions, they had a registry of 137 patients, Vanderbilt and Emory, it looks like the institutions, where they treated 137 patients with catheter-directed therapy for PE. Again, a mix of massive and submassive. Some of these using ultrasound accelerated, some using standard catheters. In both of these segments of the trial, it seems like the massive was about 20% of the patients compared to 80% submassive. Mortality, those patients, about 3.6%. Intracranial hemorrhage, 1.4%. The 2 patients in their registry that had intracranial hemorrhage, major bleed. Otherwise, I says essentially patients that had to have transfusion. When I then roll that into a meta-analysis, and look at 860 patients over 16 studies. The mortality was low for submassive, was 13% or so for the massive. Intracranial hemorrhage of all these trials put together was only 0.35%, and major bleeding about 4 to 5%. So improved, but the trouble is that the numbers of patients in each of these trials compared to the systemic is considerably less. And in fact, of these patients that had intracranial hemorrhage, there are only 3 patients that are reported in that meta-analysis. 2 actually are from their own registry that did that, which makes that a little bit harder to look at. And let's see if this will advance. A little help from the back, maybe, guys. Let's see if I missed one. Can you roll back one, make sure we didn't miss a slide? I guess not. Okay. All right, so standard treatment then for PE, breaking down by the groups. Here we go. So low risk PE, I think there's relatively homogeny in terms of the recommendations and consensus for that. Essentially, that's anticoagulation for patients with low-risk PE, so without the hemodynamic changes, et cetera. Should that be home therapy? And in fact, the new CHEST guidelines say, yeah, they do suggest home or early discharge over standard hospitalization. That's pretty encouraging. For the high risk or massive PE patients, CHEST guidelines say those are patients with systolic blood pressure of less than 90, that they do suggest systemically administered TPA over no such therapy. So supportive care for those patients, anticoagulation, obviously systemic lysis if their bleeding risk is reasonable. They do state, as they go through and choose systemic over catheter-directed thrombolysis, that essentially that's because of the quality of the data, right? There are more patients with bigger studies, with more rigorous control, and that's the reason they go with systemic, because the evidence for that is higher than it is for catheter-directed. For patients that don't do too well, then they do talk about catheter-directed embolectomy as well. Intermediate, woof, the ball's up on this one, right? Really hard to say. So again, CHEST guidelines, to go back to that, because I think those are sort of the standards that many of us would at least fall back on and anchor our decisions with. So most patients, acute PE, not associated with hypertension, against systemically administered thrombolytic therapy, right? Yeah. Must be playing on the PC back there instead of the Mac. So for patients who, so they do go through though and say for patients with acute PE who deteriorate, but yet maybe not yet into massive, to those patients to at least consider thrombolytic therapy. And then they go through and say, okay, you may not have a blood pressure less than 90 yet, but if you're having these other things, you're starting to look shocky, et cetera, then consider anticoagulant therapy. And for patients with anticoagulant therapy who should be getting thrombolytics, but those who seem to not, then they do go through and talk about using catheter aspirations. So from JVS, there was a paper not too long ago in 2015 that talked about what to do through this, and essentially it came down to talking about the same multidisciplinary team concept that we've heard talked about before for patients with severe RV strain, worsening function, et cetera, to say, should those patients be considered for cardiac surgery and embolectomy, or should they be considered for systemic thrombolysis or catheter-directed thrombolysis? And that if they're not improving, that really to consider surgical thrombectomy or aspiration thrombectomy, particularly if they can't have thrombolysis. The European Society of Cardiology guidelines that we've heard some about earlier, again, sort of come through and talk about for the patients that are in the intermediate high risk, to consider more aggressive therapy. But again, not a clear thing to say, yes, they absolutely should have it. And I think that really comes down to then what's their bleeding risk and their patient factors in terms of their otherwise expectations. So for patients that are intermediate risk, the ones that should be really considered for evaluation and possible interventions more so than anticoagulation would say patients with RV strain by echo or CT. At Methodist Hospital here, they're actually now starting to change the reporting on pulmonary embolism positive CT scans to include the RV-LV ratio, which I think will be somewhat helpful. Patients with positive markers, particularly the positive troponin, reasonable functional status and bleeding risk, and then multidisciplinary decisions and possible catheter-directed or surgical interventions. So here we have ongoing treatment for thrombolysis for DVTs. It's been going on for several years, including in and out of trial. Systemic TPA is delivered in multiple settings for massive PE, both several of the ICUs and down the emergency room as well. There have been occasional surgical embolectomies for massive PE, including some fairly notorious cases where patients have come back from near dead and now walking around and doing really fantastic. But that's the challenge, right? And that I'm sure Dr. McGover would talk about is if you wait until they're dead, then bringing them back to life makes it much harder. So ongoing CPR clearly not a good prognostic factor for that. PE, catheter-directed therapy, and catheter aspirations are done, and increasingly those are being done with more discussions beforehand. There's an oncoming trial for the FlowTriever Inari device that you'll get to put your hands on out in the exhibits and upstairs for catheter aspiration for PE. And then complex PEs have been really been driving the process to say we really need to formalize this PERT team process, and we're working towards that. So you're going to call these clotbuster guys, right, and see how that goes. So briefly, I'm just going to go into what about DVTs, right? I think although it's fairly well known, it's still not always thought about, right? So patients with DVTs, are there clear guidelines? Well, the only thing that's really clear is that they all disagree, right? So American College of Chest Physicians says essentially anticoagulation therapy alone over catheter-directed lysis, although it does acknowledge that patients may want to have that if they place high value on post-thrombotic therapy, post-thrombotic syndrome. AHA and SVS both, however, say consider first-line treatment of patients with iliofemoral DVTs, right? So not femoral popliteal, but iliofemoral DVTs for early thrombus removal for post-thrombotic syndrome, decreasing incidence in particular for patients with early symptoms of this that you can get within 14 days of onset. The CAVENT trial has been published with a follow-up study pretty recently. This is a Norwegian trial where they randomized 200 patients to anticoagulation alone or that plus catheter therapy for patients with iliofemoral DVT and showed significant improvement in post-thrombotic syndrome and in venous patency at 2 years. A 5-year follow-up study was just published recently, which showed persistent improvement in post-thrombotic syndrome. So patients have something like this with swollen, discolored leg and significant discomfort after thrombolysis can have dramatic improvement. And having some patients that come back to us with post-thrombotic syndrome with a shriveled up, chronically swollen leg that then progress on to venous ulcers is a really terrible problem. And it's been estimated that half of patients with iliofemoral DVT can progress to this. But it's not all DVTs, obviously, right? Iliofemoral DVTs. And the problem is the duplex report does not say iliofemoral DVT, right? But if the common femoral vein is thrombosed, then that's a patient with an iliofemoral DVT. And if it seems like a good risk patient, I would say those are patients that should be considered for possible referral for thrombolysis. Thank you.